All right, we are going to move on to our second plenary for the day. I'm honored to introduce Dr. Christian Yo. He is a cardiologist who attended medical school at SUNY Downstate in Brooklyn, residency at UT Southwestern, and his cardiology and EP fellowships at the University of Washington. He's an assistant professor of cardiology and a medical director of electrophysiology at Northwest Hospital. He's presenting today on Turn the Beat Around, Reevaluating Rhythm Management for Atrial Fibrillation. Thanks so much.
Thanks so much for that kind introduction. It's nice to meet you all. And thank you so much for having me to talk today about atrial fibrillation. Can you all hear me? Okay, is that,
Yep.
yes? Okay, perfect. Um, just to start off the slides, I have no relevant disclosures for this talk. But my only potentially relevant disclosure is that I am an electrophysiologist who does ablations, and so there might be a little bit biased because I love to do ablations. In terms of what we'll be going over today, first we'll take a historical timeline of atrial fibrillation management. We'll look at some of the foundational studies in rate versus rhythm control. We'll take a look at catheter ablation and its impact on rhythm control, specifically in a couple of higher risk populations. And then we'll talk about a landmark study called East AFNet, which has really changed the tide in terms of how we look at patients with early in their course in atrial fibrillation. And then I'll close up with a little bit about some new technologies, and we'll go over some conclusions. So atrial fibrillation was first likely described in 100 BC in a Chinese manuscript, which described an irregularity of the pulse. But it wasn't until 1628 when William Harvey first described fibrillation of the auricles in animals. And it was actually as early as 1785 that physicians started using digitalis for heart failure, which resulted in regularization of the heart rhythm, which you could sort of consider the first use of antiarrhythmic medications for atrial fibrillation. But it really wasn't until 1909 that atrial fibrillation as we know it was defined, and it wouldn't be until the 1970s and 80s that medical management first emerged for atrial fibrillation, which with medications that were initially developed to treat angina and ventricular arrhythmias like amiodarone, sotalol, disopyramide, flecainide, and propafenone. In terms of catheter ablation for atrial fibrillation didn't develop until much later on. The first ablation was actually performed by accident in 1979. The story is that a patient was being brought to the electrophysiology lab for a diagnostic electrophysiology study, and the patient had multiple episodes of ventricular tachycardia, and they required sequential cardioversions, and damage was caused to the His bundle by a nearby recording catheter, and that caused permanent AV block. So that was a really, really interesting sort of finding. In 1982, Mel Scheinman at the University of California in San Francisco and his colleagues developed the first catheter ablation. And it was in 1991 when atrial fibrillation rhythm management really came into the fore in terms of ablation. The first rhythm management surgery was described by Cox with the Cox-Maze cut and sew procedure, and it was not until 7 years later that really catheter ablation came to the mix when Hassegaer and his colleagues in the Bordeaux group published their paper on the basis of all ablation for atrial fibrillation that is formed today by finding out that a majority of atrial fibrillation starts with triggers that occur in the pulmonary veins. And this is a kind of very rudimentary drawing here that was published in the New England Journal. You can see only about 60 patients here that they found that the pulmonary veins is really where triggers for atrial fibrillation started. given that this concept of atrial fibrillation has only been around for about 30 years, there have been really vast improvements over a short period of time, with the most recent one being pulsed field ablation for atrial fibrillation ablation, which has really significantly improved the efficiency and potentially the safety for atrial fibrillation ablation. But we'll really start our examination of rhythm management for atrial fibrillation in the early 2000s with some of the foundational studies in antiarrhythmic medications. So the first study we'll talk about is the AFFIRM study. I think many of you are probably already familiar with this study. It was included patients who were 65 years or older and had one other risk factor for stroke or death, and a high likelihood of recurrent atrial fibrillation needing long-term therapy. This was a multi-center randomized control trial among 213 centers in the United States and Canada. The study compared rhythm control versus a rate control strategy. And notably, as was usual clinical practice at the time, patients who achieved sinus rhythm for 4 weeks with the rhythm control strategy could stop their anticoagulation, because during the early 2000s and the late 90s, we thought that once we got rid of atrial fibrillation with medications, you really didn't have that significant risk of stroke anymore. That has changed, as we'll see later on. The primary endpoint for this study was a hard endpoint of overall mortality. And they also took a look at secondary composite endpoints of death, disabling stroke, and anoxic encephaly, and major bleeding and cardiac arrest. 4,060 patients were randomized to either rate or rhythm control, and this study showed that there was really no significant difference between the two strategies in terms of mortality. However, there was really, you can see here, there was a trend toward worse outcomes, increased mortality in the rhythm control arm. When we look at the secondary endpoints, patients in the rhythm control group had more frequent torsades de pointe, more frequent cardiac arrests from PEA, bradycardia, or other rhythms, and more frequent hospitalizations after baseline. We can kind of explain this more frequent hospitalization after baseline because in order to start an antiarrhythmic, you may need to be admitted to the hospital, and that's the practice then, and that is still the practice now for many of the antiarrhythmics we start for atrial fibrillation. And then pulseless, like PEA arrest, bradycardia, and torsades de pointe are kind of self-explanatory. We know that antiarrhythmic drugs can cause QT prolongation and bradycardia. But interestingly, when the AFFIRM authors looked at secondary analyses, they found that excess mortality was primarily driven by non-cardiovascular death, with the majority of deaths being from cancer or pulmonary causes. Both cardiac and stroke deaths were not significantly different between the groups. It's kind of a little bit of food for thought here, and perhaps in looking at the subsequent analysis where the AFFIRM investigators looked at sinus rhythm, drug treatment, and baseline variables in secondary analysis, they really found that sinus rhythm was associated with improved survival. They also found that warfarin use was associated with improved survival, while rhythm control drugs down here was associated with decreased survival. So what are some of the takeaways from this study? Sinus rhythm may be beneficial, and it might be a mistake to stop patients' anticoagulation after they've achieved rhythm control. Several other studies were published in this era. You can see 2000 to 2008. The PIAF study, the RACE study, which was actually published in the same issue of the New England Journal as the AFFIRM study, and AFCHF. And they really all showed no significant difference in clinical outcomes, with some signal for possible harm in patients on rhythm controlling medications. So all of these studies in the early phase of rhythm control really showed potential harm. It wasn't until a later study, the J-rhythm study, where we began to see some signal that rhythm control may be beneficial. This study included paroxysmal atrial fibrillation patients and randomized them to rhythm control or rate control. And the primary composite outcome here in this study was an interesting one. It included all of your typical outcomes like death, stroke, systemic embolism, major bleeding, hospitalization for heart failure. But it also included an endpoint of physical or psychological disability requiring alteration of the assigned treatment. So essentially, if people could not tolerate their atrial fibrillation for some sort of symptoms in the rate control group, then that would be considered a failure. A majority of the patients in this trial were treated with class 1C agents, including flecainide and propafenone, which you may commonly see in practice currently. A few of these are sort of older medications, and then the majority of patients were on pilsacainide, which is basically class 1C that is only marketed in Asia and still in use today. The study authors found that patients in the rhythm control group did significantly better than patients in the rate control group with a p-value of 0.012. And the primary endpoint was really mostly driven by patient-reported physical and psychological disability requiring change in the rate and rhythm control strategy. So potentially a marker here that in terms of quality of life, patients do better with rhythm control. There is it does show here that mortality, embolism, and bleeding heart failure, was perhaps slightly better in the rhythm control group, but there is no statistical significant difference. And again, these are secondary analyses, not the primary analysis. The next study, the next sort of big foundational study that came out was the Athena study. And this was a study that was, a drug approval study. And it enrolled patients with both paroxysmal and persistent atrial fibrillation, at least one of the following. This is really sort of like a risk-enhanced population at age greater than 70, cardiovascular comorbidities like hypertension, diabetes, prior systemic embolism, a large left atrium, or heart failure with an LVEF of 40%. Patients were randomized to either dronedarone, which is a class 3 agent, or placebo. And the primary outcome was first hospitalization for cardiovascular event or death from any cause. The study was actually, the study inclusion criteria were actually changed at the interim analysis because there was lower than expected mortality. So the age cutoff was increased to 75 or 70 with an additional risk factor. 4,628 patients were enrolled, and the study authors found that a significant improvement in the composite outcome of hospitalization and death in patients on the rhythm control medication dronedarone over placebo. Outcomes were primarily driven by first hospitalization due to cardiovascular event rather than mortality. Mortality, you can see here, kind of overlaps and had a non-significant difference. So, just bring those all together. In the early era of rhythm control with medications, rhythm control was not better than rate control. Composite outcomes showed a trend towards favoring rate control, actually, over rhythm control. However, later studies utilizing class 1C agents and dronedarone, which is class 3, showed potential benefit for rhythm control, but the vast majority of studies showed a signal towards harm. Some of the bright points out of all those studies was that in patients who achieved sinus rhythm, outcomes were generally better. And so that kind of hinted at a potential benefit of rhythm control if a better method of sustaining it could be found that was not as toxic. That brings us to the ablation age. And the first study we'll look at is a study called ATAC. This study looked at patients with persistent atrial fibrillation and heart failure with reduced ejection fraction with a dual chamber ICD or a CRTD. And the reason to have these is that they wanted to look at the overall arrhythmia burden in their outcome. So having a continuous monitor for atrial arrhythmias was helpful. They randomized 203 patients to either ablation or amiodarone, and their primary endpoint was an endpoint of freedom from atrial fibrillation, atrial flutter, or atrial tachycardia off of antiarrhythmic drugs. So this was basically any atrial arrhythmia outcome. And when we look at their table 1, this was generally a younger patient population here. Age was on average 60 to 62. With an EF in the range of 30%. So a relatively low EF here. in both groups. And most patients were on some form of guideline-directed medical therapy at the time. Again, this was 2016, so we didn't really have ARNIs or SGLT2 inhibitors, but 90+% of the patients were on ACE or ARB. 70 to 80% were on beta blockers, and about 40 to 50% were on MRAs. The study investigators found that patients undergoing catheter ablation not only had better freedom from atrial arrhythmias, with 70% free from atrial arrhythmias in the catheter ablation group, they also had lower rates of unplanned hospitalization and lower overall mortality in secondary outcomes. So, this kind of raised the question of, could ablation be the intervention that people had been looking for to improve frequency of sinus rhythm without the negative side effects of antiarrhythmic drugs? Castle AF was a second noteworthy study published on the heels of ATAC in 2018. This study randomized 397 patients who had either paroxysmal or persistent atrial fibrillation. Importantly, they had failed or did not want to take an antiarrhythmic drug, and they had NYHA class 2, 3, or 4 symptoms with an LVEF of less than 35%. Patients had a medical optimization run-in. So they got all of them on good GDMT before the randomization. And then they were randomized to either ablation or medical management of atrial fibrillation. And medical management was whatever the prescribing doctor, usual care, considered usual care at the time. The primary outcome was a composite outcome of death or heart failure hospitalization. And patients were relatively younger. The mean age was 64, and were generally somewhat symptomatic, but not severely so. So there was only 2% of patients with class 4 symptoms. Majority had, class 2 to 3 symptoms, and relatively few, 10% or so, 10 or 11% or so, had minimal symptoms. Notably, the study had a significant number of patients with persistent or long-standing persistent atrial fibrillation, with 70% persistence, which we think of as generally tougher to treat than paroxysmal patients in terms of rhythm control. What the study showed was a significant difference in the composite outcome of death and heart failure hospitalization, and this was consistent across both the subpoints of death and hospitalization. And when we looked at subgroups, the outcomes were really also consistent across all subgroups, including persistent and paroxysmal atrial fibrillation patients. NYHA class, although they only really included class 2 and 3s here because there were so few class 1s and 4s, and non-ischemic and ischemic cardiomyopathy. The only group that seemed to potentially not benefit, and there was a positive interaction term, with an LVEF of less than 25%. And perhaps this points to the fact that these patients may have been too sick to benefit from this strategy. So we have 2 studies showing a possible benefit of ablation in patients with atrial fibrillation and heart failure. Cabana was a kind of like the next big study. It was a large multi-center randomized controlled trial trying to generalize this concept to the broader atrial fibrillation population. It included patients who were 65 years or older or younger than 65 with a stroke risk factor for atrial fibrillation. So you can recognize this kind of as a CHA2DS2-VASc score of 1 or greater. Patients were randomized to either catheter ablation or antiarrhythmic drug therapy. And the primary endpoint was all-cause mortality, but was eventually modified to a composite of death, disabling stroke, serious bleeding, or cardiac arrest. And this was because there was overall low mortality in the initial patient population. There's a fairly wide age range here. A mean age of about 68, but 15% of the patients or 14% of the patients were older than 75, and about 33% of patients were younger than 65. A similar range of paroxysmal and persistent patients, if you see down here as Castle AF. And then importantly, a majority of these patients had at least some symptoms from atrial fibrillation. So this is the Canadian class score or cardiovascular score for atrial fibrillation severity, and 0 here is asymptomatic. 1, 2, 3, and 4 are symptomatic. So only about 10% of patients were asymptomatic atrial fibrillation. And when we look down here at the rhythm control, this is prior rhythm control therapy, 80% of the people in this trial had tried at least one antiarrhythmic drug prior to the start. So results of Cabana were somewhat underwhelming. On the intention to treat analysis, there was no significant difference between drug or catheter ablation in the primary composite outcome of death, disabling stroke with a modified Rankin score of 2 or greater, serious bleeding, or cardiac arrest. But there was significant crossover in both groups. About 10% of patients assigned to ablation never received an ablation, which is interesting. And 2% of them really didn't get ablated for at least a year. And in terms of the drug therapy group, you can see 72 and 73% remained on drug therapy, but more than a quarter of the patients actually crossed over to ablation during the follow-up. So how do we interpret this? Well, the strategy, when we look at strategy, the strategy of initial ablation versus initial antiarrhythmic medication may not be significantly different in terms of outcome. But what about the therapeutic effect of atrial fibrillation ablation versus antiarrhythmic drug? The study authors subsequently published some data on their per protocol analysis, which I think partially answers this question. Again, fraught data, since it's a secondary analysis and a per protocol analysis rather than the intention to treat analysis, which the randomized controlled trial is meant to be used as. But when we look at patients who are on protocol at 6 months and 12 months, there's a significant decrease in the primary outcome when treatment was assessed at 12 months. So significant decrease, although a borderline statistical significance, but you can see here that catheter ablation patients look like they did better over the time period, and that seemed to be a durable response over the 60-month follow-up. Beyond the primary outcome, Cabana was also powered specifically to detect a difference in quality of life. The study authors really kind of emphasized this when they were in their study design. This is a busy slide here, but the Cabana authors looked at 2 scores, the effect score or the AF effect on quality of life score, where higher numbers are better quality of life, and the MAFC, which is the Mayo Atrial Fibrillation Specific Symptom Inventory, with lower numbers here being better. And what they found is that similar across both of the quality of life metrics, patients who had ablation had significant improvements in their quality of life. Looking at this, both patients with catheter ablation and drug therapy improved over the time period. But atrial fibrillation ablation patients had a significant improvement over those with drug therapy. And so far, we've seen that rhythm control with ablation may hold a substantial benefit in certain subgroups, specifically heart failure with reduced ejection fraction, and that ablations may be more effective than medications at improving quality of life, and in an albeit potentially flawed analysis, improving potentially hard cardiovascular outcomes like stroke, heart failure, hospitalization. The paradigm of management for atrial fibrillation, though, really reaches a sea change with EAST-AFNet-4. Which was a very large European study, and it enrolled patients with recent onset atrial fibrillation, that is, a diagnosis within 12 months of or randomized within 12 months of diagnosis from atrial fibrillation. And it was generally a higher risk population. So they looked at patients with age greater than 75, prior stroke or TIA, or 2 of the following: age 65, female, hypertension, diabetes, CKD, LVH, or coronary artery disease. So this is kind of like a little bit of a Chad's VAST plus score. And they randomized patients to usual care versus early rhythm control. And early rhythm control meant antiarrhythmic drug or ablation and cardioversion of persistent atrial fibrillation. Usual care patients were initially treated with rate control, but could be switched to rhythm control to mitigate atrial fibrillation-related symptoms despite adequate rate control. The primary outcome was a hard outcome of death from cardiovascular caused stroke or hospitalization from heart failure or ACS. And the secondary primary outcome was days in the hospital. When we look at what kind of patient population, about 30% of this patient population were asymptomatic, but a majority had mild to moderate symptoms. East AFNet was actually terminated early for efficacy, with 2,789 patients randomized to either rhythm control or usual care. And in the primary outcome of death from cardiovascular-caused stroke or hospitalization from heart failure or ACS, early rhythm control was favored with a hazard ratio of 0.79 with a p-value of less than 0.005. So a pretty significant outcome here. And these trends were really similar across all sub-endpoints. When we look at the rhythm control that patients got, this is the group who actually got rhythm control, and this is the group that were usual care. A majority of the patients had medical rhythm control. So this is really a study of medical rhythm control, just like AFFIRM, with overall relatively low crossover to the usual in the usual care arm. So now this goes in really stark contrast to the findings of earlier studies like AFFIRM, PIAF, RACE, and AFCHF. So how do we explain this? Yang and colleagues reanalyzed the AFFIRM data and stratified patients by new AF diagnosis, that is a diagnosis within the last 6 months, and an old diagnosis greater than 6 months. And they found that even in the AFFIRM data, when they looked at kind of an East AF-NET4 population, they found no significant difference in outcomes between rate and rhythm control for the primary endpoint of mortality. This was really reproduced for the other composite endpoints of East AF-NET4 of stroke and cardiovascular hospitalization. In fact, what they found is that in multivariate regression analysis, assignment to rhythm control was associated with a significantly increased risk of death with a hazard ratio of 1.48. So in stark contrast to the results of East AF-NET4. How do we reconcile these two things? What were some of the key differences in East AF versus AFFIRM? Again, both of them were primarily rhythm control medication trials. But what we can see here is that, the number of patients on antiarrhythmic drugs, the kind of antiarrhythmic drugs significantly differed. So a large number in this patient population, in East AF-NET used dronedarone and flecainide, both of which we know from Athena and the J-Rhythm study were potentially more beneficial than rate control. And in addition, remember that warfarin use was associated with improved outcomes in AFFIRM. In East AF-NET4, this was the era of DOAC, and more than 90% of the patient population in East AF-NET4 were continued on DOAC, appropriately so. So this may kind of explain to us why there are differences between East AF-NET4 and AFFIRM. But if the AFFIRM sub-analysis didn't corroborate East AF-NET4 data, can we still trust East AF-NET? And the answer that is hard to say, but we can look at some observational data. Observational data, two big studies that I'm going to talk about here. One was by Kim and colleagues that kind of tried to replicate in two different in a different cohort study. Kim and colleagues looked at the Korean health insurance system, and they looked at patients treated with early rhythm control versus rate control. And what they found is that there was a significant improvement in composite outcome of cardiovascular death, stroke, or hospitalization for heart failure, or ACS. This is the same exact outcome as East AF-NET with a significant p-value. Again, this is retrospective data. It's claims data. So there's that comes with all of the caveats with that kind of data. Dicko and colleagues found a slightly differing result when analyzing the Optum Labs data, which is a US-based claims database, and the UK Biobank data, which is a UK-based research database. And what they found is that early rhythm control was associated with improved composite outcome for all-cause mortality, or stroke or hospitalization with heart failure or ACS in patients with a high comorbidity burden. You can see that here, p-values of 0.006 or 0.009 in the CHADS basket greater than or equal to 4. But in the low cardiovascular mortality group, there wasn't such a difference. So these are slightly in conflict with the general findings from EASD-AFNet-4, but really food for thought. Furthermore, when a group of authors performed a meta-analysis of randomized controlled trials, including EASD-AFNet, rhythm control was favored over rate control for the outcomes of cardiovascular death, stroke, and heart failure hospitalization. So this includes all those early trials we talked about, PIAF, AFFIRM, RACE, and then some of the Athena, and some of the later trials like CASTLE-AF, EASD-AFNet-4. For all-cause death, there was no statistically significant difference between rate and rhythm control, but there was a trend favoring rhythm control overall. So how did guidelines change as a result of all these studies? The top here, we can see the old 2020 atrial fibrillation guidelines. In that guideline, atrial fibrillation ablation for PVI should or may be considered as first-line therapy to improve symptoms in selected patients with symptomatic paroxysmal atrial fibrillation. This was 2A. This was updated in the 2024 guideline to a class 1 recommendation where catheter ablation is recommended as the first-line option with a shared decision-making rhythm control strategy in patients with paroxysmal atrial fibrillation to reduce symptoms, recurrence, and progression of atrial fibrillation. In addition, there was a new statement that received a 2A recommendation that implementation of a rhythm control strategy could be considered within 12 months of diagnosis in selected patients with AF at risk of thromboembolic events to reduce their risk of cardiovascular death or hospitalization. And this is kind of directly from the EASD-AFNet-4 study population, as well as the subsequent studies looking at UK Biobank and the Optum database. In terms of the AHA HRS guidelines, early rhythm control change. It used to be that a heart rate control strategy less than 80 beats a minute was reasonable for symptomatic management of AFib. But the 2023 guidelines suggest that in reduced LVEF and persistent or high burden atrial fibrillation, trial of rhythm control strategies should be considered. In addition, catheter ablation was updated as sort of a potential first-line therapy to improve symptoms and reduce progression of persistent atrial fibrillation in generally patients who are younger with symptomatic paroxysmal atrial fibrillation. So that's kind of the trajectory currently of rhythm management in atrial fibrillation and the pivotal studies that we've done. I'm going to talk a little bit more and shift towards the new technology that's come out called pulsed field ablation, and talk about the older styles of ablation that still exist and are still used for other kinds of ablation other than atrial fibrillation. So the earliest kind of ablation that we used to do is something called radiofrequency ablation. And essentially what happened is that a catheter was placed into the heart and radio frequency energy was passed through that catheter to a grounding patch that was on the patient's skin. And this energy caused resistive heating at the site of contact with the catheter. That resistive heating, that heating caused conductive heating in the surrounding tissue. And really, it was conductive heating that caused tissue damage and ablation in the for a majority of the area of myocardium. During cryoballoon ablation, a refrigerant, usually liquid nitrous oxide, is pumped into a balloon or catheter in contact with the tissue surface, and that causes tissue necrosis. For radiofrequency ablation, myocardial necrosis occurs at about 50 degrees Celsius. And for cryoablation, ice formation and subsequent necrosis occurs around minus 15 degrees Celsius. Pulsed field ablation has emerged as a new technology for atrial fibrillation ablation. It relies on the effects of a strong electrical field on cell membranes rather than thermal energy. And what happens is when you apply a strong electrical field to the patient's lipid or phospholipid bilayer, some of those phospholipids end up flipping in the direction of the electrical field. And that causes pores to form in the electrical field. In addition, some of the voltage-gated channels remain open. And when these pores form, they can cause sort of a change in the intracellular concentrations of various electrolytes, and that cause cellular lysis. Um, its primary advantage is actually that it has more selectivity for cardiac muscle cells, which means that collateral damage to, for example, smooth muscle cells in the esophagus or myelinated axons in the phrenic nerve are minimized. There is, uh, kind of relationship between the electrical field strength and the pulse duration that's delivered when we do these electrical pulses. And you need to get enough pulse duration and enough electrical field strength to cause irreversible electroporation rather than reversible electroporation, but not to get into such high pulse durations or strengths that you cause thermal injury, which kind of obviates the improvement in outcomes in terms of smooth muscle injury and myelinated axon injury. Several IDE studies have shown both safety and efficacy of pulse field ablation as a modality for treating atrial fibrillation, with an primary efficacy endpoints in the 70% range, similar to that in thermal ablation, and pretty good primary safety endpoints. Most studies have shown non-inferiority when comparing pulse field ablation to thermal ablation. But one study recently published in March of 2025 called Single Shot Champion showed that there was definite non-inferiority, but the superiority endpoint was actually achieved with a p-value of 0.046. So this is the percent of patients with recurrence or recurrence-free. There was a significant difference between pulse field ablation versus cryoballoon ablation, which is the traditional thermal ablation technology. Is pulse field ablation safe? And the answer is probably yes. This is the Manifest 17,000 study, which included over 17,000 patients in a post-approval registry undergoing pulse field ablation, and it showed that overall PFA energy-related complications are very low, much less than 1% here. The non-energy specific adverse events are pretty similar to previous: cardiac tamponade, less than 1%, stroke and TIA, less than 1%, death, much less than 1%, vascular injury, 0.3%. That's in terms of major vascular injury. Minor vascular injury is 2.2%. But it's important to note here that there's a couple of adverse events that are not really seen as much in thermal ablation, specifically coronary artery spasm, which can cause ST elevations intraprocedurally. These are generally intraprocedural complications, and then hemolysis related renal failure. So there's some studies that are ongoing now that are looking at this. But the thought is that if there is not good contact between the catheter and the tissue, that that electrical field can actually hemolyze red blood cells, and that those hemolyzed red blood cells can cause pigment nephropathy. And in a very rare situation, that can cause temporary need for dialysis. But all of these patients have sort of recovered in terms of their overall kidney function. So what are the questions still remaining? There's many ongoing trials, and there's many significant questions. Some of the ones to look out for are EAST high AFNet 11. This is the same group that did EAST AFNet 4. And what they were looking at as high comorbidity burden, that's a CHA2DS2-VASc of 4 or greater, and cardiovascular endpoints. Specifically, they're wondering about stroke here, whether an ablation can improve stroke in patients with a high comorbidity index. Avant-Garde is a study currently ongoing looking at pulse field ablation versus antiarrhythmic drugs in persistent atrial fibrillation. And then CABA, HFpEF, and stable SR4 are really studies that I think the whole electrophysiology and cardiology community are awaiting with bated breath. They're looking at catheter ablation versus medical therapy in patients with heart failure with preserved ejection fraction. Because as you remember, CASTLE-HF and ATAC were both in patients with reduced ejection fraction. Emerge Cryo is another study looking at patients with an ER visit for atrial fibrillation and getting them directly towards ablation after their initial ER visit. And then SMILE AF is a study that the University of Washington is actually enrolling in. Dr. Uyanga is the site PI for the study. She's looking at additional ablation for paroxysmal atrial fibrillation for pulsed field ablation in patients with, and looking at if beyond the pulmonary veins, if there may be some benefit to doing additional ablation with PFA. So in conclusion, rhythm management for atrial fibrillation has evolved significantly over the last 30 years. Contemporary studies show a significant benefit for rhythm management in certain subpopulations of AF, specifically heart failure and early in the course of atrial fibrillation. Early rhythm control should be at least considered in all patients at the time of diagnosis. And ablation methods are evolving, and pulsed field ablation has been shown to be safe and effective. And there are several ongoing trials which will help determine further who else may benefit from early rhythm control. And that's all I have for you today.
Wonderful. Thank you so much. I know that there are many people in the crowd applauding right now. I